as we see, we are approaching two epidemics, that is heart failure and atrial fibrillation. And if you find the elderly population and better management of hypertension and myocardial infarction is a major contributor to this. There is a great need for the drug. There is no specific drug in these situations. There are no FDA approved drugs. Only in heart failure reduced ejection fraction, beta blocker is there. Nearly 20 to 30% of atrial fibrillation develop heart failure, and 20 to 30% of heart failure develop atrial fibrillation. So, if you go to NOHA class 1 around 5%, and if you go to class 2 around 10%, 3 around 20 to 30%, and around NOHA class 4 is 50%. It is twice common in heart failure with preserved ejection fraction. If you see Asian population, here according to the heart failure preserved ejection fraction and reduced ejection fraction, Chinese, Indian, Malay and all these things, India have a lesser prevalence, maybe this underdiagnosed. These are the risk factors which are common to both heart failure and atrial fibrillation: is advanced age, obesity, coronary artery disease, hypertension, diabetes, sleep apnea, kidney disease and smoking. All these things lead to systemic inflammation, endothelial dysfunction, oxidative stress, neurohormonal activation of RAS and ANP release, ultimately leading to LV hypertrophy, fibrosis, dilatation, and enlargement, increased LA pressure, fibrosis, leading to heart failure preserved ejection fraction and reduced ejection fraction and atrial fibrillation. They are interchangeable. So amyloidosis has come up as a new entity, which there can be isolated atrial amyloidosis giving rise to atrial fibrillation and heart failure preserved ejection fraction. If you see the mechanism as I show, heart failure can lead to increased filling pressure, dysregulation of intracardiac calcium, neurohormonal activation, ultimately leading to increased LA size, leading to atrial fibrillation, and atrial fibrillation in turn can lead to heart failure also. This is the interplay or interdependence between the different risk factors, mechanisms between the heart failure and atrial fibrillation. They have shared and synergistic mechanism in heart failure or atrial fibrillation. This can be simplified in this diagram. So they have a crosstalk between heart failure and atrial fibrillation because they are shared risk factors and shared pathophysiology, and that is called shared epidemic or a syndemic. So a syndemic is the hallmark, the presence of two or more disease states that adversely interact with each other, negatively affecting the mutual course of each other's trajectory, enhancing the vulnerability, and which are made more deleterious by experience inequities. So we are facing this syndemic. There are several preventive strategies for heart failure and AF Nexus, starting from achieving the euvolemia, amyloidosis, RAS blockers, heart rate control, all these things in heart failure and atrial fibrillation, preventing the development of atrial fibrillation, restoring the sinus rhythm, all these things. If you look at this algorithm, this can treat, just to remember, C stands for cardioversion, it's signs of hemodynamic compromise. Anticoagulation, when it is indicated according to Chadva score, and normalize the fluid balance, that is keep euvolemic, targeted initial heart rate less than 110, renin angiotensin RAS blockers are important, and early consideration of rhythm control, that is very important. If you come back to sinus rhythm, that is you remain in the state where atrial booster is preserved. Otherwise, even if heart rate is controlled in atrial fibrillation, atrial booster is lost. In advanced heart failure therapies and treatment of other diseases. This is the flow diagram to manage heart failure with atrial fibrillation. If it is sinus rhythm or paroxysmal atrial fibrillation, then maximal tolerated beta blocker dose should be given. It may be metoprolol, bisoprolol or carvedilol, with maximally tolerated sacubitril valsartan dose after prioritizing the beta blocker optimization. Empagliflozin, dapagliflozin, spironolactone next come in the picture. If there is permanent AF, again low dose beta blocker to keep the heart rate stable, and digoxin if needed for rate control, and maximally tolerated sacubitril valsartan empagliflozin spironolactone again comes to play. If persistent heart failure, despite medical therapy, consider catheter ablation. New onset AF, tachycardia, cardiomyopathy, and atrial valvular regurgitation, consider pharmacologic rhythm control. You see, these are the evidences shows the ARB, this S inhibitors, statins, beta blockers, and PUVA have been found to be helpful in clinical trials, not PUVA. Yes. This coming to the preserved ejection fraction, no definite trials. Benefit of antiarrhythmic drug is not established. Early rhythm control in AF with HF, heart failure preserved ejection fraction is important. Just according to different trials, alcohol cessation, weight loss, anticoagulation, and SGLT2 inhibitor role are under investigations. If you see the guidelines, ESC guideline, the lifestyle modalities is very important. So you have to identify and manage the risk factors and concomitant disease recommended age in integral part of the heart failure patient, AF patients. Modification and unhealthy lifestyles and opportunity screening of AF in patients with hypertension and in these patients with obstructive sleep apnea and weight loss in patients when obese. If you see here, we'll have to detect atrial fibrillation. You need a high index of suspicion. The smartwatches has come up to detect AF. There are total 18 studies of smartwatches examining atrial fibrillation in more than 4 lakh patients. It has been found that sensitivity is around 100%, specificity 95%, and accuracy is 97% detecting the AF. Because unless you detect AF early, you are going to treat it. So AF with HF, rhythm or rate control. Always rhythm control is the best. Rhythm control, pharmacologic or electrical cardioversion is superior to the strategy of rate control. This is also latest data where it shows dual antiarrhythmic medications of amiodarone and flecainide better than amiodarone alone. If you come to the rhythm control, sinus rhythm restoration is very important. This can be done with electrical cardioversion if there is urgent, only if there is life-threatening episode of AF or indicated in the first episode of AF, but not indicated in paroxysmal or permanent AF. Amiodarone is the main therapy for this. There are numerous side effects. The dopetylide is efficient for sinus rhythm maintenance. If you see this ideal rate, what is the ideal rate? There are lenient and strict control they have compared. Lenient is, they are identical. So resting ventricular response should be 60 to 80 beats per minute, and a ventricular response of 90 to 115 during moderate exercise has been suggested. Rate control, this reduce the rate, improve LV function and heart failure symptoms. If it is not control, rhythm is control is not possible, we then go for rate control. Beta blocker has been proved to be helpful, and CCB, particularly non-dihydropyridine calcium channel blockers, amiodarone and digoxin where it is indicated. Regarding the ablation, the Castle AF study shows the primary composite endpoint of death from any cause or hospitalization for worsening heart failure was lower in ablation group. And a study that catheter ablation of AF was superior to amiodarone in terms of achieving freedom from AF in long term and reducing the unplanned hospitalization and mortality. And anticoagulation, if the Chart-Bass score is 2 or more in male and 3 or more in female, it is required. BK is given only in mechanical valves and moderate to severe mitral stenosis. And NOACs or DOACs are preferred. And similarly, they are more effective than BK. And LA occlusion is required whenever it is indicated. What the ACCSA guideline says, the patients with chronic heart failure with permanent or persistent paroxysmal AF with Chart-Bass score more than equal to 2 in men and more than equal to 3 in women should receive chronic anticoagulation therapy. And this anticoagulation therapy, a DOAC is recommended over warfarin. So these are the currently available measures starting from preventing the coexisting heart failure and atrial fibrillation. That is more important. Here, ACE inhibitor, ARB, beta blocker has a say, and treatment of hypertension, diabetes, and sleep apnea to the target. And rate control, rhythm control, and acute management are important. There are 4 pillars of intervention that are linked in heart failure. So lifestyle or risk factor management, here obesity, sleep apnea, physical activity, hypertension, diabetes, alcohol intake, smoking, CAD and heart failure are to be taken care of. Anticoagulation where we indicated, regime control is ideal, but not possible, go for rate control. So how can we break the jinx? So we'll have to adopt to the healthy lifestyle, address the risk factors, optimal GDMT for heart failure management, early diagnosis and treatment of AF in HF, use of RAS blockers because they prevent incidence and prevent recurrence of atrial fibrillation, anticoagulation to prevent stroke, achieving sinus regime. So the golden rule, because non-communicable diseases are increasing, healthcare cost is increasing, so prevention is the soul of 21st century. Ladies and gentlemen, AF and HF can cause or exacerbate each other. In the presence of heart failure, optimization of GDMT, consideration of catheter ablation and management of contributory lifestyle factors is important in AF management. With smart health technology and lifestyle intervention, preventive strategies will be our best shot at breaking the AF, HF nexus and halting the epidemic. Thank you for your listening.